Okay, let's unpack this.
Hmm.
We're diving into, I think, one of the highest stakes areas in healthcare, that moment when capacity is lost.
Right.
And clinicians, well, they have to make these huge, life-altering decisions. I mean, imagine the scenario. It's straight from the source material.
Okay.
You have an unbefriended patient, they've got severe delirium, and they need urgent, high-risk surgery. It's not immediately life-saving, but it is urgent.
And they lack capacity.
They lack capacity right now. No family, no paperwork, no advance refusal, no power of attorney. Who decides? And, how do you make that decision legally sound?
That scenario really is the crucible for the Mental Capacity Act 2005.
Yeah.
The challenge is just immense because when an adult loses that capacity to decide, the decision stops being purely clinical.
It becomes a legal process.
It becomes a structured legal process. Our duty shifts from, getting consent to carrying out a lawful, proportionate best interest assessment.
Exactly. And acting in their best interests. It sounds simple, but in the UK, it is so highly regulated. I mean, quick fixes or just asking a relative to sign a form.
It completely fails.
It fails the test.
Our mission in this deep dive is really to give you that essential framework for navigating these situations. We're focusing on the critical tools, the MCA Section 4 checklist, the mandatory involvement of people like an IMCA, and, crucially, the documentation. You need that paper trail.
To protect the patient and to protect the decision maker.
Exactly. This is about making a sound decision safely.
So the foundation for all of this is the Mental Capacity Act, the MCA from 2005. It's all about protecting the patient's autonomy, right?
Yeah.
Centering their wishes even when they can't voice them.
That's the core principle. And it brings us straight to Section 4.
Okay, so what is in this legally mandated checklist, and where do people most often, get it wrong?
Well, Section 4 tells you the mandatory factors you must consider. And it actually starts by telling you what not to do, which is often more revealing.
Oh, interesting.
You are explicitly told not to base the decision on the person's age, their appearance, their condition, or their behavior. It forces you to look past any prejudice.
So if the patient is elderly and frail, you can't just decide against treatment because, they've had a good run.
Precisely. Or if they're difficult to manage, you can't just pick the easiest option for the staff.
Right.
And that leads to what you must do. And this is the heart of it all. First, you have to consider their past and present wishes, their feelings, beliefs, and values.
Which means you actually have to do some digging.
You have to do some genuine investigation. It's not just a quick look at the notes. This is the bit that so often gets missed on a busy ward.
And consultation is a big part of that, I assume?
A huge part.
Yeah.
You must consider the views of anyone caring for them or close to them. And this isn't just a courtesy call. Neglecting that input is often the first thing a court looks at. It shows a failure to investigate properly.
We also have to think about the future, don't we?
Yes. You must consider if the person might regain capacity. For example, will their delirium clear? And if so, can the decision wait?
Okay.
And finally, the big one for protecting their rights. You must choose the least restrictive workable option.
So if you've got two options that work.
But option A requires heavy sedation and option B doesn't, you have to go with option B. That is the lawful path.
So the real takeaway here is that structured, lawful reasoning, actually mapping your decision to those 5 points, is the only way to be safe. Speed and convenience just don't matter if the process is wrong.
They're legally irrelevant.
I think this is where it gets really interesting and a bit more complex, because these decisions aren't made in a vacuum by one doctor.
No, not at all.
There are legally mandated people who have to be involved. So let's look at those mandatory consultation points, starting with that unbefriended patient from the start.
Okay, so for that person, the one needing serious medical treatment, the law is crystal clear. You are required to instruct an independent mental capacity advocate, an IMCA.
Let's just clarify that term, unbefriended. Does that just mean they don't have any family? What if they have a really close long-term friend?
That's a great question, and it's a key distinction. Unbefriended means they lack capacity and have no appropriate family or friends to consult.
Appropriate.
Yes. The decision maker has to judge if the people around them are genuinely able and willing to represent the person's best interests, free from conflict. If that network isn't there or it's not appropriate, you must call the IMCA.
It's a legal safeguard.
It's a statutory safeguard. Ignoring that trigger is a clear breach of your duty under the MCA.
Okay, huge point. Now, what about prior wishes? The advanced decision to refuse treatment, or ADRT. This sounds like the most powerful voice the patient has left.
It is. A valid ADRT is legally binding if it applies to the current situation. It overrides everyone else.
Yeah.
Clinical opinion, family, even a lasting power of attorney for that specific treatment. But for life-sustaining treatment, the rules are really strict. It has to be written, signed, witnessed, and very specific. You can't just ignore it because you think a treatment might help.
You have to verify it and apply it.
You must.
Okay, so what about the other key player, the lasting power of attorney, or LPA? If the patient appointed their daughter, for instance, isn't she the final word?
Another common misconception. And it's where a lot of friction can happen. The LPA for health and welfare is appointed to decide on the patient's behalf, but they're not replacing the patient.
They're an agent.
They're an agent, and their decision must still meet the best interests criteria under Section 4.
Hold on, so if the patient trusts their daughter enough to give her an LPA, why can the clinical team still challenge her if they think she's not following Section 4?
Because the LPA's power is one of substitution, not total sovereignty. If the LPA's decision goes against clear Section 4 factors, say they want something highly restrictive when there's a better option, or they're ignoring the patient's known beliefs, the clinical team has a duty to challenge.
And potentially go to court?
Potentially, yes.
Yeah.
It's there to prevent abuse or decisions being made based on the LPA's preferences rather than the patient's actual rights and wishes.
So that sets up our immediate red flags, the things that should set alarm bells ringing.
Exactly. 3 main ones. First, if you have an unbefriended patient needing serious treatment.
Instruct the IMCA immediately.
Yes. Second, if there is any hint of a valid ADRT.
You stop, you verify it, and you respect it.
And third, if you're looking at a plan that seems coercive or highly restrictive.
You have to justify it as the absolute least restrictive option available.
You've got it.
Yeah.
So knowing the legal rules is one thing. Applying them when you're under pressure is something else entirely. We need a clear, reliable, stepwise framework, a sort of mental checklist to guide you from the problem right through to the final record.
Okay, let's run through that. The high-yield stepwise actions. This is the practical bit.
Right. Step 1, confirm capacity. This has to be the very first thing you do.
And for this specific decision at this specific time.
Yes, and it has to be linked to an impairment of the mind or brain, like the delirium in our case. If they have capacity, the process stops. The patient decides.
Okay. Step 2, apply the MCA Section 4 checklist.
Precisely. You rigorously go through it. You gather the information on their wishes, values, beliefs. You consult the right people. You cannot skip this step.
Step 3, involve the mandated players.
Then you bring in the IMCA or the LPA or the whole MDT is required. If it's serious treatment and they're unbefriended, the IMCA must be in that conversation before final decision is made.
And step 4, you called the ethical hammer.
I think it is. You must choose the least restrictive workable option. It's non-negotiable. If treatments A and B are clinically equal, but B preserves more independence.
B is the lawful choice.
It is.
And step 5, the one that makes it all count, documentation.
Document the people, the options, the rationale, and a review date. And this brings up a really crucial concept, proportionate process.
So not every decision needs a huge hours-long meeting.
Not at all. A simple, low-risk decision, maybe routine blood tests, just needs a concise best interests note. But something serious, complex, or disputed, like our surgery scenario, that demands a structured best interest meeting with clear minutes and a named decision maker.
To help remember all that, the source material gives us a great little memory hook. BI log.
BI log is fantastic shorthand. B for beliefs and wishes. Did you center the person? I for involved. Did you consult the IMCA, LPA, MDT, L for least restrictive option? O for options and risks mapped to Section 4, and G for generate a clear record.
Perfect. And just to close that loop on the wider context, the deprivation of liberty safeguards, DOLS, that's still the law of the land for now, right?
It is. The new Liberty Protection Safeguards, or LPS, haven't been implemented yet. So if your best interest decision does end up restricting someone's liberty, you still have to follow the DOLS process.
Okay, so we've laid out the right path. Now let's talk about the pitfalls, the things designed to trip people up. The decoy detectors.
Yes, these traps almost always involve training proper process for what feels like a quick fix.
Right. Let's hit trap 1. Do it quickly because it's urgent, and we'll write the rationale later.
Fails every single time. The MCA requires a contemporaneous rationale. When you make the decision, you have to map out the Section 4 factors and record them then and there.
A court won't accept something written days later.
No. It basically invalidates the lawful process.
Okay, trap 2. I've seen this happen so many times. Ask a relative to sign the consent form.
That is a spectacular failure. Relatives are not default decision makers in UK law. They can't sign consent. Their role, under Section 4, is to provide their views on the patient's wishes.
So trying to get them to sign gives you no legal cover at all.
Zero. You're just shifting an institutional duty onto a family member. The decision must be owned and documented by the clinician.
And track 3. Delay indefinitely to find family or wait for capacity to return.
This fails the second that delay becomes unsafe or disproportionate. You have a legal duty to act in the patient's best interests now.
So for our opening scenario with the urgent surgery,
You have to act. You use a proportionate process, instruct the IMCA, apply Section 4 rapidly, and you proceed. An unsafe delay is just as unlawful as not consulting anyone.
let's test that then. For that scenario, the best action was B, instruct the IMCA, apply S.4, document, and proceed. Why does delaying option C score so badly?
Because the surgery is urgent. Delaying is unsafe. Now, if the surgery were elective, then waiting for capacity to return might well be the least restrictive best option. But here, the urgency forces your hand. It pushes you straight to the IMCA in that proportionate meeting. We really can't say this enough. The whole rigorous process we've just discussed, the consultation, the S.4 checklist, it's all legally vulnerable without a robust, clear record.
The documentation.
The documentation is your proof of a lawful process, and it's your professional protection.
This is where we link the law, the MCA, back to professional standards like from the GMC. So what makes a record defensible versus indefensible?
A defensible record explicitly shows you're working. An indefensible one just states a conclusion, like decision made for surgery based on best interests.
Which tells you nothing about the process.
Nothing at all.
So what are the absolute essentials that have to be in that record?
Okay, first, the capacity summary. Why do they lack capacity for this decision? Second, all the wishes and values you consulted on, who you spoke to, what they said about the person's beliefs. Third, involvement details. Every single person consulted, their name, their role, and critically, the IMCA or LPA involvement.
And what about the decision itself?
The record has to list all the alternative options considered with a clear analysis of why the path you chose is the least restrictive one. And the final decision needs a rationale that is mapped directly back to the MCA Section 4 factors.
So you literally write, we chose this because of the patient's known beliefs, S4 factor 2, after weighing the IMCA's advice, S4 factor 3,
and confirming it's less restrictive than option X, S4 factor 5. That level of detail is exactly what the GMC expects for robust record keeping and, well, good medical practice.
So we've covered the whole framework. Let's quickly recap the 3 key takeaways that you need to remember from today.
Okay. First, every single best interest decision must center the person's wishes and values, and it must follow that MCA's Section 4 checklist. No exceptions.
Second, always use the mandatory advocates, the IMCA or an LPA, when they're indicated. But remember, they are also bound by that same duty to find the person's best interest.
And third, always choose the least restrictive workable plan and leave a clear, contemporaneous, defensible record. Detail every step and every bit of your rationale.
So what does this all mean? The challenge of best interest isn't just about keeping someone alive. It's about making a choice that maximizes that person's rights and autonomy, even when they can't speak for themselves.
And that leads to the really deep dive challenge, I think. Applying Section 4 when the legal instruments themselves seem to clash.
What do you mean?
Well, you might face a situation where a registered LPA wants a certain treatment, say long-term peg feeding, but you find a verified, valid ADRT written years ago that explicitly refuses that exact feeding if the patient gets to an advanced state of dementia.
Wow.
The ADRT, the person's own valid refusal, is legally binding. It supersedes the LPA's preference. So the real test is, how do you prioritize that refusal over the advocate's current request and still produce a record that explains that legal hierarchy defensively? That right there is the essence of advanced best interest compliance.